Potassium-sparing diuretics, also known as aldosterone-inhibiting diuretics or aldosterone antagonists. Potassium-sparing diuretics work by blocking aldosterone receptors. They act on the distal convoluted tubule. They work in the collecting ducts and distal convoluted tubules where they interfere with sodium-potassium exchange, so therefore blocking the sodium-potassium exchange and blocking aldosterone receptors. As a result, it increases sodium and water excretion while retaining potassium and hydrogen. These diuretics are considered weaker diuretics compared to thiazide and loop diuretics, therefore they are often used as an adjunct medication to thiazide diuretics. Therapeutic effects include diuresis with less potassium excretion, and they block the effects of aldosterone, therefore increasing sodium and water excretion while decreasing potassium excretion or retaining potassium instead. Potassium-sparing diuretics are primarily used in heart failure, so it has some cardioprotective properties, therefore they use it a lot after an MI. According to some research, it does have some cardioprotective properties which prevents myocardial remodeling. Therefore, you may see some patients after an MI or with heart failure that are on potassium-sparing diuretics. Additional indications include hypertension, fluid overload or edema, hyperaldosteronism. What happens in hyperaldosteronism? So hyperaldosteronism is basically too much aldosterone which is produced by the adrenal glands, therefore leading to a decrease in potassium and hypertension due to the sodium conservation and water retention. So potassium-sparing diuretics help with hyperaldosteronism. Some precautions include impaired renal function. Definitely we have to be careful because this medication works in the renal system, and in addition it is excreted through the renal system. Also, we have to be very cautious when giving this medication to patients who are already dehydrated to begin with, because this medication, as we know, causes diuresis, which can potentially dehydrate the patient even more. Lastly, pre-existing electrolyte disturbance, especially hyperkalemia, because it can make it worse. Some contraindications include chronic renal failure or anuria, and untreated dehydration or electrolyte disturbances, most specifically if the potassium level is greater than 5.5. Some common adverse effects or side effects include electrolyte disturbances, hyperkalemia to be specific, and weakness, as well as dizziness due to the volume depletion and decrease in blood pressure when taking this medication. If the patient is on potassium-sparing diuretics, some of these nursing actions are appropriate. Obviously, we want to measure the patient's blood pressure, intake and output beyond creatinine for the renal function, and as well as potassium and magnesium. One thing to take note is that we have to be very careful if a patient is receiving potassium-sparing diuretic in combination with ACE inhibitors, because ACE inhibitor, as we discussed earlier, can increase potassium levels. Therefore, if we give somebody something that already increases the potassium levels, such as ACE inhibitor, by giving them potassium-sparing diuretics, that can actually make the potassium levels worse, and the patient will have a higher likelihood of developing hyperkalemia or arrhythmias as a complication from the hyperkalemia. On the other hand, if a patient is at risk of developing hypokalemia and they need to be on, let's say, loop diuretics, sometimes what they do is they combine loop diuretics with potassium-sparing diuretic, therefore promoting diuresis, but at the same time decreasing hypokalemia, because it kind of cancels out the effect of the loop diuretic when it comes to the potassium by giving a potassium-sparing diuretic. Some examples of drugs in this class include spironolactone or aldactone.